or good morning. I'm Dorothy Salenti, and I'm happy to welcome you to our leadership series on the Maternal Health Learning and Innovation Center. Is a national resource center that's founded in 2019, and I am one of the members of the Maternal Health Learning and Innovation Center with partners at UNC Chapel Hill and others across the nation. Our mission is to foster collaboration and learning among diverse stakeholders, to accelerate evidence-informed interventions to advance equitable maternal health outcomes, and to do this all through engagement, innovation, and policy. And we are funded through the Maternal and Child Health Bureau out of HRSA, the Health and Human Services at the federal level. We have been hosting this leadership series this week. Hopefully you've been able to join in on some of our earlier speakers. And today, which is our third and final session, we're so excited to be joined today by Abigail Echo Hawk, who is with the Seattle Indian Health Board and the Urban Indian Health Institute. So this will be a very informal discussion. I do have some questions for Abigail, and we encourage you to use the chat as well to share any of your perspectives or ask any questions, and I'll be monitoring the chat. So before we get started, I'll just give you a little bit of background on our leadership series. We are very excited at the Maternal Health Learning Innovation Center about all the great work that's being done across the nation to improve maternal health. And we know that leadership comes from many places and many positions, and it doesn't require an official title or job or degrees. We wanted to offer this leadership series so that we could hear from leaders in maternal health and in other places, talk about their views on leadership and share some of their own personal journey. So we hope that you'll walk away inspired and maybe have some practical tips for your own growth and development as we move to advance maternal health in this country. We know that there are many leaders working to end maternal mortality and morbidity and improve maternal outcomes. And we only have the chance to talk to 3 of them in this series. However, if you want to share ideas about the kinds of leadership needed to advance maternal health, you can visit our inspiration board at any time. And there's a link in the chat. And you can put your ideas there. You can nominate people to talk in future series or in our annual symposium. So we are, like I said, a national resource, and we want to lift up the work of people in this space. So a couple of logistics before we get started. We're mostly going to be in conversation with Abigail. I do have some questions prepared, but we also want you to engage in this discussion. So if you have questions at any point, you can add them to the chat or the Q&A on Zoom. Both of those will work, and we'll try to share them with Abigail during the conversation. You are muted, but do use the chat in order to participate in our conversation. So at this time, I'm going to introduce Abigail Echo Hawk. We're so excited that she's available. She's been speaking a lot lately on the topic of American Indian health. And she is an enrolled citizen of the Pawnee Nation of Oklahoma. She serves as the Executive Vice President of the Seattle Indian Health Board, and she directs the Urban Indian Health Institute. Currently, Abigail serves on many committees, boards, and work groups, including Best Starts for Kids Board, March of Dimes, Health Equity Work Group, the Tribal Collaboration Working Group with the National Institutes of Health All of Us Research Program, the Advisory Committee for Health Equity Research at the Robert Wood Johnson Foundation, the NIDA American Indian and Alaska Native Collaborative Research Engagement Work Group, and the Board of Data for Indigenous Justice. So she has a lot of experience to share with us. She is an expert in American Indian and Alaska Native health, and she focuses on strengths and resiliencies as well as disparities. So again, Abigail, thank you so much for joining us today. And we're going to start off with a few questions. So first, can you share a little bit about your personal journey, your experience as a leader, and how you got to where you are today.
Yeah, so thank you so much for having me. I'm so excited to be here and to have this. And I think it's really important to have conversations like this in a more casual way and to be able to share the experiences that I've had in the beauty of my community. So I'm greeting you from the lands of the Coast Salish people here in Seattle, Washington, where I live and work and participate in and am part of a thriving urban Indian community. And in my role as the Executive Vice President of the Seattle Indian Health Board, I direct both and work in both clinical services and then also on the national research and epidemiology related to American Indians, Alaska Natives. And people always ask me, how did you get here? Like, how did this happen? And I always tell them, I don't know. Like, how did this happen? It truthfully wasn't. When we think about like Western concepts of leadership and careers and where and how you go in life, it's often talked about an individual decision. You know, you decide what field you want to be in, and then you go to college, and then you go through the steps, and then you find the perfect job, and then hopefully that's what you end up in. Well, from the Indigenous perspective and how my life and the work that I'm blessed to be able to do not only started but continues was by the placement of my family and my community in deciding where my skill sets were best used. And so I never made a job decision without my family. In my family, we don't make individualized decisions. We still are a collective and use our traditional value systems in doing so. And my work in public health and research epidemiology and now in direct service provision actually started with my experiences as a young Native pregnant woman who was raised in the heart of Alaska amongst my mother's people, the upper Athabascan people. I'd never been outside of the Indian healthcare system before, and I found myself in Seattle, and I was 18 and I was pregnant. And I went to a local hospital here in Seattle, one of what is seen as one of the best in the nation. And in my very first prenatal appointment, I was a terrified 18-year-old pregnant in a city that I'd never been in before, experiencing poverty. And when I went into that appointment, the medical assistant, when she saw my last name, Echo Hawk, and then she recognized I was an American Indian, she spent about 10 minutes questioning me on whether or not I had been drinking and what kind of drug use I had been doing. And she actually took my arm and pulled up my sleeve, and I realized she was checking to see if I had track marks for needle drug use. And it was so traumatizing to me that I actually don't even remember what happened when the physician came in. And I didn't get prenatal care again until my second trimester. And if we look at data on American Indians, Alaska Natives, we find that a large percentage of Native women don't access prenatal care until the second and third trimester, which again puts them more at risk for things to happen during their pregnancy to them and the child that they're carrying. And so I experienced that. It was terrible. And then one of my siblings was like, oh my gosh, there's an Indian clinic in Seattle, the Seattle Indian Health Board. And so I remember walking in those doors. And from the moment I went in, I saw people that looked like me. I experienced care that recognized me as an Indigenous person. I had Native physicians. I had support systems. I had classes to help me get through my pregnancy in a good way that were focused on and culturally attuned to American Indian and Alaska Native people. And it was because of the Seattle Indian Health Board, I was able to deliver a beautiful, healthy child. And soon, some years later, as a result of the ongoing support of Seattle Indian Health Board and our urban Indian community, I walked back in those doors as the director of the Urban Indian Health Institute and the executive vice president. And so that's what we see as leadership within the Native community. Seattle Indian Health Board built support for me in culturally attuned care that allowed me to come back to then be in service to them with the gifts of the community and the family behind me. So that's how I kind of started in it. And a lot of my work did focus on maternal and child health, because in our communities, we recognize that the health of our people who birth and their children determines the health of our entire community. And so again, my community has gifted me the opportunity to be able to be in service to them and in leadership to them in this time and space. And then my hope is, and I have 13 mentees right now, that one of them very soon takes my place.
Thank you for sharing that story. It's just awesome to hear how your personal experience has really led to this impact that you've had in your community, and now that you have mentees as well. I was actually going to ask about that, building leaders as part of your community. What do you think are key characteristics of a good leader? You shared a little bit about people who had influenced your leadership.
Yeah, and I always struggle with the word leader, truthfully. Again, in an Indigenous community, it's not about somebody who is always in the front, but rather somebody who is in service to their community and knows when to step down to let that next level of leadership come in. And so the Western concepts of leadership often aren't in alignment with Indigenous leadership. And so I've often struggled with that and been like, yes, I don't actually see myself as an expert in American Indian Alaska Native health. I see myself as a community member who has built up knowledge from the community around me that is my responsibility to gift back. And so we see this in Indigenous leadership, this idea of reciprocity, that it should always be from one gift to the other, back and forth, which is why I have so many mentees, because I was the mentee of many other Indigenous women specifically. And so recently, I say I forced her, but I didn't. I've been training her for a very long time. And one of my mentees, I was supposed to be in a panel. And I was like, Katrina, you're in the panel. And so part of it is moving them into these places and spaces where their voices should be heard. So to me, the qualities are is somebody who is willing to take critical critique from the community, be called into good practice when they make mistakes, be open to that critique and to making change, to understand that we are, as individual leaders within a field or within a discipline, we don't know it all. And in fact, we should be training up other people behind us to take our places, because they're going to have bold, brilliant, beautiful ideas that I never even thought of. And the other is the Indigenous concept of everything we do in leadership is a gift. And it is our responsibility to give the greatest gift to the community, which means you put in all of your effort, you put in all of your heart to it. And the other thing with Indigenous leadership is that we don't see ourselves as disconnected from the community. I don't go home and not think about and not be connected to the work that I'm doing. Part of Indigenous leadership is that you have a connection to the people in whom you are in service to, which means you have responsibility and accountability to them. So that responsibility and accountability is, to me, what I see is one of the greatest joys in my life. I wake up every morning, I know who I'm accountable to, and I know who I'm responsible to. And that is what has kept me in my leadership journey. And what I see is the path I'm on today. And I know that in that responsibility and accountability, the path may shift and change as my community may need me to do.
Thank you. That's a great perspective, especially having us think about how being able to lead really is a gift. And it's something that you definitely have a lot of gratitude for, and I can hear that in your responses. I wonder if you could say, you talked a little bit about leadership in Western culture, and I wonder how that has presented challenges or barriers for you, particularly within your more traditional community and how you practice leadership. So how do you navigate from your leadership characteristics and what you value to settings where there may be a different understanding or accountability for leaders?
Yeah, and I don't think we can have a conversation about leadership as an Indigenous woman, as a woman of color, without acknowledging the systems of institutional structural racism that don't want me to be in levels of leadership when I walk in the room, and in particular in the field that I'm in. I'm a scientist, and I very often am in rooms full of all white people. Very often, recently I was actually it was a couple years ago, because I don't do it anymore. I make sure I was on a panel of all men. And we see these inequities in leadership for women, for those outside of the gender binary, LGBTQ plus communities, and people of color. And as a result of that, our leadership in a Western system is oppressed and is attempted to be suppressed in pretty much every space I go into. So in the indigenous culture, you know, humility as a leader is what drives us. We don't brag about our accomplishments. When I go to my Native community, I don't like them to read my bio and to hear all the boards and commissions and things that I'm on, because it doesn't matter to them. What matters to them is I'm Abigail Echo Hawk. I'm a member of the Echo Hawk family. I am accountable to my tribal community. I am accountable to my aunties, my uncles, and my elders and my ancestors. That's what matters to them. But when I walk into these Western rooms where I have to walk into a space where I recently, it wasn't too long ago, I gave a presentation and it was at an NIH thing, and somebody sends me a message like, oh, I'm surprised by how articulate you are. It's like, is that because I'm a woman? Is that because I'm an Indigenous person? Why were you surprised that I was articulate? And so we are in these levels where when I go into these spaces, I have to do what I would never do in my own community. And that I have to assert that I belong there. And that's uncomfortable.
Mm-hmm.
I do talk about all of the committees I'm on, my qualifications, my knowledge base. And that is, it's a difference that often makes me uncomfortable, but has become necessary in the Western systems. And that's where I see the system of institutional and structural racism that also has embedded itself in this white supremacy is also embedded in Western leadership and patriarchy. And so it's a battle to be an Indigenous person in those spaces and figuring out how to navigate those to where your voice is present because it has to be, and also is done in a way that calls out those structural practices to call them back in, because a lot of people participate in them and they don't even know. They don't know they're upholding white supremacy. They don't know they're upholding institutional structural racism. The guy that sent me a, "You're so articulate," he thought that was a compliment.
Right.
He assumed I wouldn't be because of these structures of inequity. And so I like to call people into good practice. And that very often is not appreciated, but is necessary, because I think of all of the 13 mentees that I have right now. I don't want them to have to experience what I've experienced in being a leader in Indigenous science, in spaces like the National Institutes of Health, the National Academies of Sciences, all of the things that I'm blessed to be in. I don't want them to have some of the experiences that I've had. So part of my leadership journey is challenging those systems of inequity, is taking a risk, and is making sure that as I step into those places, that we bring a level of cultural understanding and begin to break down these systems of inequity, because justice for Indigenous peoples is justice for other people of color.
Right. Very powerful, especially your sense of calling people into good practice, because I know that people can be very defensive and very, emotionally unaware of their own behaviors. So I think that's a very proactive way to try to change behavior and practice. I'm going to ask you a little bit about leadership in public health and what you're doing at the Urban Indian Health Institute. So as I said, our Maternal Health Learning and Innovation Center focuses on maternal health. And we know that we need to move into action now to end maternal mortality and address inequities and outcomes. We know that we lose over 700 people every year to maternal death. So can you talk a little bit about how we can support building the leadership that we need to do this? And you talked about being a mentor. Do you have other things you'd like to share about, working in the future in this maternal health space?
Yeah, I think in building forward leadership and really thinking about the inequities that exist in maternal child health. So, I always look back to the experiences I had, and with both my pregnancies, I was considered high risk. And also the fact that in the last year, actually, it's been the last 14 months, I have assisted in burying 3 babies and 2 mothers. And we have such astronomically high rates of maternal and infant death within our communities. And the work that the Urban Indian Health Institute is doing right now is centered around a variety of different things. But where my heart is right now is really focused on the data and recognizing that the numbers that we have are a gross undercount. And in fact, when we look at vital statistic records, when we look at death certificates, we find an incredible amount of racial misclassification. Anywhere from 30 to 40% of American Indians and Alaska Natives are not properly racially identified in vital statistics and death certificates. And as a result of that, we're actually seeing a gross underreporting of race and ethnicity, which means we have higher rates of maternal and infant death than is actually being recorded. So what happens when we have higher rates than is actually being recorded? That means that we are not getting the allocation of resources. We are not being held as part of the national conversations. We aren't part of the work that is being done to end this crisis of maternal and infant mortality within our communities. And so what I'm really focused on and building leadership for the people that I'm working with in maternal and child health is to recognize the inequities within the collection of data. And people are like, oh, that's like the nerdiest thing ever. But for American Indians and Alaska Natives, the way that we are counted determines whether or not and how much the federal government upholds our treaties, our responsibilities, and the allocation of resources for healthcare. So by eliminating us in the data, they're actually eliminating the resources that are supposed to flow into our community and are eliminating their treaty responsibilities to us. I call it data genocide. They are effectively eliminating us. So I am looking for folks within this field to think about what are these systems of inequity, whether it be data, maybe you work in Hispanic, Latinx communities. You know, we are also seeing great disparities in the way that information is collected, and also within, you know, for all people who birth, not all people who birth are women. And so we need leadership who is willing to stand up and say, you know what, I see these inequities. I'm going to look and bring and gather and educate myself on the best ways for me to contribute to undoing these, and then taking action. We're hearing a lot of the word equity in this country in the last year and a half because of the pandemic, but all I'm hearing is people talking. Right. I'm seeing very little action. And so my community doesn't have time for that. They're literally dying around me. And so what we need is leaders in this field to take chances, to take risks, and to take action. And that action has to be different than what you've been doing before, because what has been done before hasn't been working. So when I think about Western equity, it is also grounded in systems of inequity, patriarchy, white supremacy, institutional and structural racism, because if the systems of Western health equity had actually worked, we would have seen some discernible difference within my community in the last 30 years in undoing health disparities, and we haven't seen anything. So what are we doing wrong? How can we as leaders in the field identify our opportunities to make systematic change? And then this is the hardest part. Are you willing to take the risk? Because it is a risk when you challenge the status quo. But it has to be done if we're truly going to see the difference that we want to see for all peoples in the United States.
Thank you so much. There is a question in the chat related to this. As a Black woman, I definitely understand the need to have to prove myself all the time. Although I can sort of fake it until I make it, I'm trying to become more comfortable with public speaking, especially in spaces where my knowledge is questioned. How have you become comfortable with navigating these spaces as an Indigenous woman? So this relates to your taking risk and being brave, right?
Not too long ago, I was in a conference, and it was, again, on undoing health disparities. I was the only Indigenous person there. And then when the leader of this huge philanthropy organization got up and began to speak, I realized that he had completely disregarded the Indigenous communities all as if we didn't even exist. And I knew I had to say something. And so just like she was saying, you know, like, what am I going to say? This public speaking thing, my heart was beating so hard. My face was probably bright red. And I jotted down my notes and I stood up and I said something. It takes practice. And it also takes, for me, the people who afterwards that I call me like, oh my gosh, I did this. I don't know if I did it right. I also have the people who are the encouragement, my family, my friends, my mentors. And I practice my public speaking. When I am getting ready for a presentation, my drive from my house to my car, or sorry, my house to my work, I basically give a talk in my car. Somebody should record my car. It's hilarious. I do a lot of practicing because the pressures of being an Indigenous woman, a woman of color, in these spaces that don't want to hear our voices, the amount of pressure and the amount of scrutiny that I am under is very different than the white woman next to me, than the white man next to me. And we have to be better. That is completely unfair. And I wish it wasn't that way. But I know I have to have everything to back myself up. And so I practice, I read every nerdy science journal that comes out. I'm one of the people who actually reads those. I keep myself up on the literature. And I also make sure that I have the supportive systems around me because another example, in April, I gave a talk at the American Association of Suicidology that was not well received. And in fact, because I challenged the systems of both data collection and also inequities, we had attempted to write a paper that went through a process at the CDC that included references to the sterilization of Native women that is in the Government Office of Accountability report. It's documented. And they made us take it out because they felt it was antagonistic, not because it didn't happen. And so I use those examples of what structural racism is and how it doesn't allow us to actually talk the truth. So when we talk about maternal health, how can we not talk about the sterilization of Native women? When we talk about chronic health disparities, how can we not talk about this injustice of on the reproductive health of our communities? And so I gave this talk at this big conference, and immediately the CEO gets a call. What are her qualifications? Who gave her permission to speak there? These attacks on my credibility and on my career. And luckily, I'm in a place in my career where I can combat those. 10 years ago, I wouldn't have been able to. And so in doing this, it's a risk. And so I always tell my mentees, my network is your network. If you take the risk that I've encouraged you to do, to stand up, to speak, to have your voice quiver a little bit, to tell them where we need to make changes in the system, and then they come at you for it, I've got your back.
Nice.
My network is your network. And so building those up as people of color, as allies and accomplices to people of color who are working in these fields, it is so essential because we are not leaders alone. And when you try to be a leader alone, you're going to fail. We have to be leaders together, and we have to support each other and see ourselves in collective solidarity. And I am blessed that I have those people, because instances like that could really ruin a career. And for me, as an Indigenous person who supports my family, could have the impacts of pushing my family back into poverty. We have to look at these systems of inequity hit in a variety of different ways. So again, how do we support each other? How do we help people practice? And I do that with my team all the time. They have to give presentations to me, which I think they hate love, because we are held to a different standard. And we also have to recognize we have to break down the systems that are holding us to a different standard.
Great response to that. There's another audience here, member here, who wants to recognize your comments around data collection and reporting of factors affecting Indigenous communities. Do you have good suggestions for pushing back against those who tell us it costs too much, or it's too much work to collect data from Indigenous communities because numbers are small, and this person doesn't even want to get into why our numbers are small? So can you speak a little bit to those issues?
This is what every single day, somebody's telling me that it's going to cost too much. They're not going to be able to gather the information, and they're not going to be able to get what they need from our communities. And I tell them, well, our numbers are small because of the genocide perpetuated against us by this United States government. And with that comes the responsibility for healing, and also comes the responsibility to uphold our rights, our treaty rights. So treaties are laws of the land. They are upheld by the Supreme Court, the US Constitution. They are the laws of the land. And so my team and I have put together, and you can find it on our website, uihi.org, a document that is called Best Practices in Data Collection for American Indians and Alaska Natives. And so it lays out what people say can't be done. But we're here to tell them not only can it be done, but we've done it. We've done it. My work around missing and murdered Indigenous women and girls specifically, which is part of my work in reproductive justice, was a report that is still today the very first national data report, the only national data report on missing and murdered Indigenous women and girls that we were told couldn't be done. And if we could even do anything, would cost millions. Well, I did it with $20,000 I self-funded. And now it's influenced 30 pieces of legislation nationwide, along with 2 pieces of federal legislation. So it has nothing to do with that it can't be done. When they say that, that is the structure of inequity. And the cost. So I'm working nationally right now on what it would look like to overhaul public health surveillance systems across the nation, both at the federal level and then also through private philanthropy. The cost, the money is there. It's about who matters. So when we talk about the cost, we can't talk about that without talking about structural racism, because right now those systems benefit white people. The cost isn't about the money. The cost is about the system. And so that's the language that I use in challenging people. And you can find supports in doing that in our document Best Practices on Data Collection for American Indians and Alaska Natives. And also, if folks are working with both Native people or other Indigenous communities, my team and I can help. Again, this is part of our leadership. We provide technical support in doing that. But also, I've been doing this for a really long time. And I have been shouting this from the rooftops for 20 years and seen very tiny incremental changes. And those incremental changes are good and they're hard, because I want to see the big changes. So we're doing the incremental, but we're striving for the big changes. And we won't do that unless everybody is making these pushes, unless everybody is raising their voices. It takes strength in numbers and communities to come together to do this.
Thank you so much. Let me ask you a little bit about some of the work you're doing around data. Your Urban Indian Health Institute says that your mission is to decolonize data for Indigenous people by Indigenous people. Can you tell us more about what that means and how that looks in practice?
Yeah, so decolonizing data and the work that we do has some very practical implications. So when we look at the way data has been used against Indigenous peoples, it has not been used in the Western culture to benefit our communities. And so data was used. So for example, I'll tell you the way data and science was used. In the Indian Wars, as they were called, the US government used to go and they would take the craniums, the skulls of Native people on the battlefields, they would boil them, and then they would send them to the Smithsonian Center, which had been established because they were measuring brain cavity, and they wanted to prove that we didn't have as large of brains as white people did. And in fact, many of those bones are still in the Smithsonian Center. Wow. And so we have that kind of data that was gathered. We have data that is often shown around health disparities to talk about how bad off we are. They want to talk about how we die, but never how we live. And as a result of data being used against us, and we actually saw it within the CARES Act with the money that came down from COVID-19, and they used bad census data to allocate the funds, which meant that some tribes got, barely anything to serve their communities. And what happened? People died. So we have data that has been used in a way that has harmed our communities from the Western culture. Very rarely has it ever benefited us. And as a result of that, Native communities have become hesitant to participate in data collection, because why wouldn't we? We needed to protect our communities. But in doing so, we actually began to then pull away from our traditional ways of collecting data. So I grew up in a community where you would go out around this lake and you would count the numbers of little beaver running around. So you knew how many you could hunt during the winter so they'd be there in the spring again. So, and when we hunted them, it was for food, it was for, we used every part of the animal. And it was also for the land to make sure that we kept the animal population in the right way. So we did it for the love of our people, to care for them, their health and well-being. And we gathered data year after year after year, iteratively for thousands of years. As a result of this Western harm caused by data, our communities weren't practicing this indigenous data concept. And so what we've been doing is trying to bring that back and recognizing we were always data gatherers, we are always data stewards. We did it for the love of our people. And there are things like the nitty gritty of things, which is in our best practices document, and decolonizing data, which means you need to disaggregate data. You need to not hide small populations. You need to gather small populations data. You need to do it in a way that looks at strengths and protective factors, not just deficits, because you want to talk about how we die, but not how we live. So practical things that really help all communities of color. And in the decolonizing of data specifically for Native communities, and this isn't meant for anybody else, is that there is a cultural and spiritual component and connection to that. There are historical stories of dreams that were used to then collect data or put forward projects around data. There were our cultural keepers, our traditional medicine people, who use their intuition and their connection to the creator and to the land to put forward the way that we interpret data and the projects that we would do. Those aren't so far in the past. They're actually guiding forward the work my organization is doing today. And that is very specific, again, to Indigenous peoples. It's not meant for other people outside of our communities. So the decolonizing data has both practical aspects for the entire nation, the entire world, and then also specific to our community. And that's what we have been rebuilding, and that is what we are directed in the work that we do. And we are now working nationwide with Indigenous communities for them to build the capacity to decolonize data for their people, by their people. And so it's a really exciting movement forward that we have national partners in, and also in the reclaiming of our culture and building forward the protective factors for our communities. Because as I think about it as an Indigenous leader, it was very important for me to know that my spiritual and cultural connections were not only seen and heard, but appreciated within my community. And so it's also an aspect of Indigenous leadership.
Thank you. A few more questions from the chat. So this question, I think, relates to what you shared regarding your experiences with the healthcare system, and also some of the positive experiences you've had and been able to lift up. Can you talk about how, what's the best way to get this kind of information to all healthcare providers?
So there are a lot of really great trainings. And there's, there was an incredible effort called Healthy Native Babies. And if you haven't seen that, it has incredible resources and tools. People say it's a little bit older, but what's in it is still incredibly valuable. It has trainings for providers talking about cultural identities, how to care for people who birth, all Native people who birth, and their children throughout the entire perinatal periods of health. And there are those resources out there. Because our community is so invisible, very often providers never see nor know that these resources exist. And so organizations like myself work as hard as we can to disseminate these as broadly as possible. Office of Minority Health, American Medical Association, whoever we can get our hands on. But we really need advocates, accomplices, and allies who can take the resources that exist, get them out to their networks of people, whether it be your listservs or your group or your mentees, and also look for opportunities to bring in Indigenous peoples who are working in this field every single day. So at my facility, we recently had a cradle board class. A cradle board is a traditional method of safe sleep. It consists of a board where a baby is on their back. They are snug, tight, and secure. And it was our traditional method of safe sleep. Cradle boards were one of the cultural practices that were immediately attacked and taken from us. And in fact, in some places, you couldn't even legally have them. So if you think about that institutional, again, why did they attack cradle boards? We're talking, it contributed and still contributes to the death of our communities. And so we see communities like mine here in Seattle and others who are rebuilding these cultural traditions. So you have to know how to make a cradle board because it has to be safe. You have to know the cultural and spiritual components of it. So we recently held one, and these were all pregnant mothers who came together with their aunties and their grandmas, and they made cradle boards, and we did what we had always done traditionally. You make them together, and then you talk about how you place the baby in it. You talk about what's going to happen during your birth. You talk about connections to child and breastfeeding and community connections and whether or not you have the resources you need and how can we help you if you don't. Those were all the same conversations that happened 500 years ago. We just did them in our clinic. It's the same conversation. And then we are bringing back traditional safe sleep. And so there are these cultural traditions that are having this resurgence that have the opportunities for people. There's an incredible hospital in Minnesota where there are elders who are making little tiny baby moccasins and are gifting them to every Indigenous baby that is born in that hospital in Minnesota. And from a cultural perspective, that gift that has a spiritual and cultural component to it that improves the health and well-being, because I've measured this kind of stuff, improves the health and well-being of the child and the mother as we think about wanting to make sure that they do incredibly well in that first year after the child is born. So things like Healthy Native Babies are out there, working with people like Cami Goldhammer, who's just an incredible advocate in this area, a national advocate, building forward baby safe hospitals that bring in Indigenous peoples who have the knowledge to chain hospital systems. The resources are there. We just need people to access them.
Thank you. A related question is how to get this information into training programs like medical schools. Have you had much interaction with some of the training programs in Seattle or other places?
Yeah, so our clinic actually is we have residents. And so we have and actually had one of the very first urban Indian residency programs. And so we have 8 residents, and we also work with the local hospital systems. And in addition to that, our team, including myself, kind of depending on the topic, but anytime we get asked anywhere, we try to go for training programs, whether it be residencies. I recently, I think last year, I spoke at 8 different medical schools related to the care of Indigenous women and girls. And so we go and we provide trainings whenever we can. And the problem becomes it's not embedded. Right. So what we need is for hospital systems and hospital systems in terms of training, medical systems in terms of training, to begin to embed within their educational offerings and what people are required to do, trainings on these things. Again, medical care very often is thinking about the general public and isn't taking into account marginalized populations, those that are being economically, socially oppressed and suppressed, and experiencing institutional structural racism that puts them and their bodies more at risk. And so as a result, we end up with providers who come into our facilities, and then we have to retrain completely. And that's a struggle. We really need to see changes at the training level where it's just not the random person like me maybe coming in once a year. How do we embed it in the actual educational offerings?
Yes, we have a lot of work to do better. And you are probably incredibly busy and, are really working hard to improve, family and community well-being. So the question is, so what do you do to take care of yourself? How do you prevent burnout? We've been hearing burnout throughout the news and, media. People are getting burned out. People are walking away from their jobs. People are retiring or whatever. What kind of self-care or spiritual practices do you rely on for your own individual well-being?
Such a good question, because over the last years of the pandemic, it has been a struggle. I've seen and experienced more death. I would say I'm just talking about the deaths, not even the other things associated, than I've seen ever in my career. I've had 6 family and friends, all under the age of 55, who have passed on as a result of COVID-19. Also seen the deaths of many mothers and babies, as I shared earlier. And it's been a struggle because I'm not distanced from this. This is my community.
Right.
These are the people that I love. And so for me, finding these coping mechanisms in a time where, the last year and a half, I probably work at the very least 60 hours a week because we have to. I took my first 5 days off a couple of weeks ago for the very first time in 2 years.
Wow.
And I was more tired after than I was before, because I realized I let my body rest a little bit. And so it is absolutely true. And I'm watching that with my team and myself all the time, that we're tired. And so what are the coping, for me, I call them coping mechanisms. So I'm an artist. I'm also a poet. I write poetry and I make art, and it's cultural art. So in the beginning of the pandemic, Seattle was the epicenter. We had an incredible amount of COVID-19, and our clinic ran out of PPE very quickly. And so we asked our partners for PPE at the federal, state, and county level. And instead of PPE, they sent us a box of body bags. And that was very traumatizing. We're a community health center. We wouldn't even use body bags. So I actually was very traumatized by that. But I actually took one of those body bags and I turned it into a piece of art. And I turned it into what is a traditional ribbon dress for Indigenous communities, and embedded in there both the tears that I had and the strength and the resiliency of my communities through my culture and my tradition. So I use that art and that poetry to connect to my ancestors and to my culture and tradition. And I use it as a way to not burn out, and to also recognize that right now, in the midst of this pandemic, people of color specifically, because I'm one of them, the pressures of what we do is so deeply overwhelming. And there has been an absolute lack of ability for us to practice self-care. And I'm anticipating that we're going to see, as a result of that, some turnovers in leadership, and also the impact on our physical health and well-being. And so this pandemic has affected us in a variety of different ways, and I'm trying to be better. So that's why I took that 5 days off. But if people are interested in my poetry and art, you can follow me on, I do that on Instagram under EchoHawk D3. And that's where all of that stuff lives.
Great. Let's put that in the chat. I'm sure you'll get followers from here. And I do want to say I'm really sorry for your losses. I know it's been a really challenging couple of years, and just to continue to keep moving forward, I'm sure it's really difficult. We have just a few more questions, and from the chat. One is specific to your mention of the Office of Minority Health. So one of our members in the audience works for the Nevada's Minority Health and Equity Office. Would like to learn more about cradle boards, other Indigenous birthing postpartum practices. Do you have any resources that you would recommend?
Yeah, so on our website at uahi.org, we have some really cool videos and resources, but Healthy Native Babies is really one of the best to go to. They have a lot of resources related around these cultural practices. And actually, we're in the middle of, my team is actually about to, we're in our second review of a very, again, a journal article specifically related to the use of cradle boards within Native communities. Because again, it's not seen as real science until we publish it, even though we have thousands of years of science behind it. So we're also working on that. But Healthy Native Babies is a really great place to go. They have toolkits you can download. They have materials. My website, uahi.org, has some In addition, you can also check out the National Indian Health Board, NIHB.org, who also has a section on maternal and child health that can also give some really great resources. The one thing that NIHB is also doing, I'll just throw a plug in for this, that if you are in your state and you are participating in maternal mortality reviews, making sure you're including Indigenous communities is very important. And the National Indian Health Board has resources and technical support to help do that.
That's great. Our Maternal Health Learning Innovation Center supports a number of states who have MMRCs, so we will share that resource with them. Related to states, there is a question about the funding that's available for maternal health innovations. And this individual wants to know, I guess, if Washington will be seeking funding, and what might some of the strategies be that you would be trying to get funding for, and gave an example that in Colorado, where this person's from, Native Americans ranked the top in maternal death, 214 per 100,000 live births. So do you have some thoughts about how you'd like to see funding be appropriated?
Absolutely, and I actually work in Colorado quite a bit. There are 2 urban Indian programs I support there, one in Denver and one in Colorado Springs. And my team, if anybody's interested in data related specifically to American Indians, Alaska Natives, for example, I have a community health profile of Denver with more than 31 different health indicators, including maternal and child health, on our website, uihi.org. So please, if you're looking for data related to communities, you can go there. The things that we would like to see that are being called for, and actually there's been a lot of efforts at the federal level with the Biden administration, and also some incredible work being done by Representative Wynn Moore from Wisconsin, to look at and to address very specific things where we see a lack of funding. Doulas, making sure that we have funding for and reimbursement for doulas, midwifery, and the ability for people to birth where they are the most comfortable and the most safe. And then looking at investments in workforce, both in trainings and also to bring forward people of color to be the ones who are serving their communities, because we know that absolutely makes a difference. And then what does it mean for culturally attuned care? So my team right now, I oversee our policy team, and we have traditional Indian medicine people who work at a parallel level with our physicians on the floor of our clinic. We've been documenting that. We have been working with some managed care plans in the state of Washington, where we are looking for reimbursement of our traditional Indian medicine people to make these practices embedded, and also making sure that we can continue to pay for them and have our people have access to them. So we have created a model of reimbursement through managed care plans for traditional Indian medicine, which would include things like cradle board classes, because those are safe sleep. You're going to have a child have safe sleep for the first 9 months of their lives in that cradle board in a traditional way that a Native family is comfortable with. And that makes a huge, huge difference. And so we're doing these things and piloting them in Washington state, but I'm also working on the federal level and with some other states right now and interested parties. We have an entire reimbursement process laid out. We've actually have 2 managed care plans who are doing that reimbursement process with us for these traditional Indian medicine people. And again, having conversations at the federal level with the Biden administration on what it would look like to reimburse for traditional Indigenous medicines and care. So a lot of really cool things going on that I'm really open to sharing, especially if we can get other people to think about how you push initiatives like this forward.
Those would be amazing policy changes. And it makes me think about, how we talk about science-based practice, but really we need to be thinking about practice-based science. Mm-hmm. So in our last few minutes, if people remembered only 1 or 2 key messages from listening to you today, what would you want those messages to be?
Leadership is about service, and it's about community, and also about knowing when it's time to bring in the bright, brilliant, beautiful ideas of the people coming up from behind you. So always mentor, always let those people lead. And I'll leave you with the words of one of my elders who told me when I was a young person coming up in this, walk in front of me because you were born to lead. And for all people of color, know that you are coming into spaces and places where your voice is unwelcome, but you are bright, you are bold, you are beautiful, and your voice needs to be there. So walk in front. You were born to lead.
Thank you so much. That's an amazing message to leave us with. So in closing, I want to thank you very much again for taking the time to share your experiences and wisdom with us. And again, remind the audience, if you want to share ideas about the kinds of leadership that's needed to advance maternal health, please go to our inspiration board at any time. The link is in the chat. And also, please feel free to nominate other people who you feel would help build your own leadership skills. And we'll try to make sure that we can get them online to talk with you. And then lastly, you can find out more information about our website, maternalhealthlearning.org. And we have lots of resources from this session that we'll be trying to share with you through that resource site. So at this time, thank you again for participating. I really feel inspired by what you shared with us today, Abigail, and I hope that we can collaborate in the future. So everyone have a good afternoon or rest of your day.
Thank you for having me.
Thank you so much.